welcome to another webinar here at Beyond Marketing. And today, before the holiday season, we have a very, very special guest and a very wonderful partner of ours. We have Ignacio Handal, or Iggy, from Clinicom here joining us today. And Iggy is actually the CEO of Clinicom Healthcare. He's completed a multitude of FDA phase 1, 2, and 3 studies in pharmaceuticals and devices over 2 decades. He's completed more pharma-sponsored clinical research studies than 99.8% of all clinical researchers internationally per globaldata.com. So the man is very seasoned in the research and clinical research side of things. Mr. Handel has completed clinical studies that have helped put a myriad of drugs and devices to market over the last 20 years. And these products have touched the lives of over 200 million patients in its capacity. In 2022, Iggy was honored with the highest honors in clinical research, the Christine Pierre Clinical Trials Lifetime Achievement Award. So congratulations on that, Iggy. And only 8 clinical researchers have globally ever been awarded for this honor. So with that being said, our partner at Clinicom, Iggy, we're happy to have you here. Thank you for joining us. Let's get into it. What is Clinicom and what are we doing here?
Well, first of all, let me thank you guys for having us on, and we really value our partnership with your company and the amazing work you guys are doing in the TMS space. So I really just want to start by saying, thank you to our partners, and also really excited about empowering both our clients with the unified offering that is going to really revolutionize TMS care and ketamine care in the marketplace, and really empower those clinicians to have better clinical decision making, have more TMS patients in chairs, but also not waste a lot of time on things that right now might be slowing down the process. So I'm happy to jump in and share a little bit of that. So Dr. Noel, what would you like to drive as far as your main overview? Would you like us to?
Well, so basically, for a lot of our clients that are in the provider space, whether you're offering TMS, ketamine, medication management, counseling, assessments are really key. Diagnostics are really key, and it's not as consistent as it could be. So if you had to summarize in a quick statement of what exactly Clinicom is and what it does, I know that's not as easy to do because we have a lot of information to share. What would you say who Clinicom is and what you guys do?
So I think in the basis is that from one adaptive, there's a lot of measurement tools out there, especially in clinical research. There's hundreds of them, and clinicians have a hard time deciding which to use and how to layer them. And so we really remove that challenge in saying, hey, you might not know your patient yet. You might be screening somebody you have never met before. What comorbidities do they have? What medication, what history they come in with? And so what we do is we adaptively screen autonomously through a link or a text message for 80 DSM conditions, screen, assess, and present to the clinician what the comorbidities may potentially be, what the criteria that they met are, what other flags or features they may have in their history, so that you can basically understand your patient before they walk in the door and decide what level of care and kind of coordinate to the right cost and level of care. And for TMS and Spravato, that can be very challenging when you have maybe a phone screener who may not be a medical professional, who's trying to understand and ask these questions or trying to assess the history and bring them in. And so we're also saving time from those clinicians so that the people they're evaluating are more in line with the treatment they're providing. And if they're not to that level yet, tracking and monitoring them over time until they may be service.
So what would you say are some of the barriers that you have seen in this space for mental health providers and other providers in the space overall when it comes to the diagnostic element in terms of screening and scales and measurements and what we've conventionally seen in the field? What do you think some of the barriers have been?
I think it's patient engagement to begin with. If the patient doesn't understand why this potential specific treatment may be better than the stuff they've tried, really a lot of time wasted with patients that are not yet ready for these treatments and somewhere in the cycle. And how does a mid-level provider or a phone screener really work through those patients to really make sure that they're optimizing their clinician's time and value, but also optimizing the outcomes for the patients? How do you simultaneously do both for both? And I think we can accomplish that through this presentation and our products.
So basically, it's like saying any mental health patient that calls into a facility is being screened with a PHQ-9, and that's conventionally what we're doing on a large scale, is using one sole modality of measurement or assessment that is not really painting the whole picture because mental health diagnoses aren't so black and white. Is that something that you see quite often in terms of clinics and providers you've talked to, that there's not enough on the diagnostic level?
Yeah, absolutely. I think there's an epidemic of that really in our industry. There's a lot of digital mental health point solutions out there, screening with very light screeners that they won't even allow us to use as primary endpoints in FDA trials, right? So why won't the FDA allow us to measure with just a PHQ-9 if somebody has depression? And the real answer is because it's not as sensitive specific as a HAM-D, or it's not as accurate as looking through all the criteria of the DSM and really looking at that differential diagnosis. There's people that score low on a PHQ-9 that have high suicidality. There's people that score low on a PHQ-9 but probably meet the definition of major depression if they were evaluated through the DSM criteria, not that light screener that is batting in the high 80s maybe percentile. And that is for somebody who might have known depressive symptoms, not somebody that you're just screening from a phone call, right?
Agreed. It's like having somebody measuring. Yeah, no, it's like having somebody measuring high on a PHQ-9, but the primary diagnosis can be anxiety based, and a GAD-7 wasn't done, and we're really missing out on those key components and key symptoms. And from what I understand,
right? Like, so what if they have, like, a patient presents depressed and you said, oh, PHQ-9's high, but they have manic symptoms or had a manic episode in the past, but right now they're presenting depressed. If you didn't check for the mania, you might, a lot of primary care docs are prescribing SSRIs and putting people in the emergency room. So there's a lot of risk in doing it the wrong way. And that's why we really want to show how we did it the right way, so that we don't drop balls, miss comorbidities, miss things that you need to know for these specific TMS and ketamine treatments. Do they have seizures? Do they have heart issues? Have they had hallucinations in the past? Are they sensitive to medications that might induce psychosis and other things? So, let's dive in. I'd like to share a little background, and then, if we have questions, stop me. I'm gonna be able to see the hands raised, but I'd like to, share a little bit about us and what we do. We've obviously done a lot of clinical trials. Here.
Sorry, Iggy, just really quickly, just to let everybody know, we have some attendees in. Thank you for joining. If you have questions, there is a Q&A. You can throw them in there. We'll do our best to get to each question, and we'll have them answered at the end of this presentation. Iggy, the floor is yours. Thank you.
Thank you. So, Doctor, in general, in sharing our background and our expertise in measuring mental health, we've been doing it for large pharma and large CROs for over 20 years. We've helped put, close to 90% of the CNS drugs to market that have come to market in the last 20 years, specifically in the pediatric CNS space. Our CNS research site that we own, Harmodex Neuroscience Research, has been partnered with, some of all the companies listed here on the slide, but many others. So a big litany of research that we've done over many, many years. We also have, not only the background in clinical research, but our chairman is a distinguished fellow of the American Psychiatric Association. We won the, I think it was like first runner-up in the APA Innovation Lab a few years ago. We've started research sites for also one of the largest surgical centers in the country, and obviously currently serving with Clinicom as CEO. In summary, Clinicom is the world's only comprehensive mental health platform that can assess and monitor 80 mental health conditions from a single adaptive machine learning assessment using adaptive augmented intelligence and current clinical standards. So in a nutshell, the difference between that and maybe some competition or an EMR screener, or maybe a product you might be using out of your TMS provider chair platform, is most of those tools are GAD-7, PHQ-9, stacked assessments, maybe a couple others, and that's it. So they assume that the patient has these problems, they're point solutions, and there are screeners, light screeners, are not really to the level of looking at DSM criteria. And the other issue there is, what about everything else, right? What if they're schizophrenic? What if they're Asperger's? What if they have learning disabilities? What if they have insomnia? What if they have every other, social phobia? What about all these other things? Humans are very complex. We're not just GADs. We're not just GAD and depression. And so looking at people in that really narrow lens means you're missing a lot. So Clinicom, the other thing is, those stacked assessment companies, you stack assessments after, one after another, and you hit a certain threshold of 4 or 5, and people quit answering them. They feel tone deaf. The questions aren't tailored to the person. It's not tailored to the age group, the sex, who the reporter is. Why are you asking me schizophrenia questions? I don't have schizophrenic symptoms. So the difference here is also Clinicom is adaptive. So if you don't have those symptoms, I'm not going to ask you 30 more questions about it. And so we are going through checking for 80 conditions, but doing so adaptively. And so it asks the appropriate questions at the right time. It integrates to most EMRs. It's HIPAA compliant. It's FDA Part 11 compliant for research. The security level is like none other. It's twice the level of your bank. So if you trust where you put your money, you can trust our data security twice that to that level. It's secured in motion at rest. And most importantly, private health information is decapitated from answers to questions, stored in one database, encrypted in motion at rest. Answers to questions are encrypted and stored in motion at rest in a different database, and never shall the two meet until you as a clinician call for it with an API key and encryption. So if we're ever hacked, they have no idea what your answers were, and we will never, ever sell personal health information. That's just our mantra. High level, what does this do for TMS, and how does this help TMS scale? Let me move this out of the way here. I think it's blocking you. So, the biggest challenges addressed in operating a successful TMS site is really how can you automate the assessment of your patients? So if you could just snap your fingers and get a report card on every one of your patients that call for potential TMS or Spravato or any other behavioral health treatment for that matter, and could, look at a report card on that patient, full report of what DSM criteria they meet and see what, if they meet criteria, clinical standards for prescribing TMS and Spravato, your life would be a whole lot easier. And that's what we're going to show you today. We've had, this is not a product that we're just putting into the TMS space. We own TMS clinics. We have 2 TMS service locations for our family of businesses. And we also have been providing this service to the world's largest TMS centers that, have 131 locations and are in 30 plus states. So we're able to do this at scale. And Clinicom reduces the intake burden and the team burden. So it's a full force multiplier, taking one phone screener and making them like if you had 3. It also can double the conversion rate, and it has doubled the conversion rate at the world's largest TMS center. So they've reduced their time to treatment by 22 days. They have also doubled the number of TMS patient seats in chair, so occupied chairs per month for those locations. With Clinicom, you'll be able to track potential patients at different stages of TMS or Spravato treatment applicability while enjoying the full benefits of a reimbursable mental health platform. So that's the other thing, is that this is reimbursable for MDs and PhDs and some nurse practitioners in some states. So Clinicom is also, you can think of it as the engine of modern TMS centers, right? It empowers the largest TMS center in the world. Clinicom assesses for contraindications, 80 conditions. It automates your intake. It creates additional revenue streams. It creates bandwidth for your clinicians and your team, improves the workflow so you guys can focus on being clinicians and not paperwork and not checking boxes. Clinicom provides deep data analytics and on-demand real-time evaluation of treatment efficacies, and you'll be able to track your potential patients at different stages. So trying to go through the slides rather quickly because I'd rather focus on sharing the product. But Clinicom really has many domains, so it's not just an assessment for ketamine or TMS. You're gathering all the information on the screen, right? It's everything. It's a complete biopsychosocial assessment. It gathers chief complaints. It gathers the medications, the history of medications. It's a full assessment. It also captures other domains, and this is the optional stuff, which we have a Clinicom standard product, and we have a product called Clinicom Pro. So if you go with the Pro version of the dynamic single send assessment, so you think about it as 2 comprehensive global assessments, Clinicom Pro and Clinicom. They both screen for 80 conditions. Clinicom Pro gathers this deeper information about quality of life, social determinants of health, etc. I want to just emphasize that Clinicom is not a survey. We have 255 algorithms. All our questions are copyrighted since 2008 and continue as we expand. The algorithm questions are first person, third person, and pediatric. So you just send to Clinicom, and Clinicom figures out who the reporter is, what the relationship is to the patient, their age level, what appropriate questions to ask, and starts them down a tree of questions and decisions. And as you answer questions, different algorithms open up. So this is just one example of one of our algorithms of the 255. But if you don't need to answer these extra questions, it doesn't ask it of you. So the example I would give is if you said you were in the military and you were hit in the head, it would deploy the military history questionnaire and TBI and some others. And if you said you were in the military, why do I need to ask you about military history? Right? If you have no symptoms of schizophrenia, why do I need to ask you 30 more questions? So it gets through the triaging very quickly. The value for the patients is they feel heard, understood, and like never before from their couch with a glass of wine, and are able to tell their complete mental health journey and story to you without taking up your time as a clinician. So when they walk in the door, you get that report, you get all that content without them feeling rushed out of a room. This is so cathartic for patients to be able to tell their clinician what they've always wanted to share, but are sometimes scared to do and wait till the 5th or 7th visit to do so. So this is, accelerating the course of care, accelerating engagement, accelerating uncovering comorbidities, and making your patients feel like I found the right clinician, I found the right clinic because they care and they listened. And when you actually see the patient for the first time, you're going to be empowered with all this data, and you won't spend your time running down rabbit holes. You'll actually be addressing the key critical issues, heat map to severity. There's a couple bullets here, but I'm not going to waste the time. There's a tremendous value for clinicians. Just put aside the reimbursability of this product that can range from $60 to $120 to do a Clinicom for most insurances across the country for MDs or PhDs. Put aside the revenue stream and the business model. This is going to just really empower clinicians to lower their clinical workflow burden, clinical documentation burden. It's going to help you track and trend, how medications if medications are being effective or not, and really reduce the number of visits to stabilize your patients. We really think you're going to really enjoy this and the augmented intelligence behind it. There's obviously tremendous value for research. I'm not going to go over this slide. We obviously do a lot of research, but if you do some of that, there's tremendous value there. There's tremendous clinical utility. We talked about some of those. Remember, this is for 80 DSM conditions. And at any point in this training, if you decide that you want to learn more, you can go to Clinicom/onboarding to look at time and scheduling. Remember to note that you got this from Beyond Marketing as well. And then Beyond Marketing also has a free trial link. So I would, don't use the one here. I think Rand and the folks at Beyond Marketing could send you their Beyond Marketing trial link, so you have the integrated link for the offering.
Yes, we will.
Connects the two. Yeah. And then, we're supporting both. And the workflow here is very simple. There's not a lot to do. We try to take as much of the burden off of you as possible as a clinician, and just hand you results and let you make clinical decisions, and not, bore you with having to decide what to send. So your technician or scheduling person would just literally type in an email and a phone number and hit send. We can automate that process through EMR integration and automation. So when you create your patient EMR, it auto sends. The clinician literally just looks at the report, reviews the report, accepts or rejects the suggested diagnosis, and then orders a follow-up. The billing department literally looks at that document. There's a literal billing section. They can look at the billing opportunities. It tells them what codes, the time requirements, and what they've qualified for, and makes this super easy to do. So very few tasks and actual work for anybody to do, because nobody needs more buttons to click. So we are capturing that full DSM biopsychosocial assessment, but we're also, for this product, we have layered over some specific TMS and ketamine algorithms that will assess and triage TMS and Spravato or ketamine workflows. We'll go over reviewing the report, how to look at that triaging, how we'll cut down time to treatment by almost half, how to review, accept, and reject the diagnosis, and just look at some of the clinical shortcuts. So having said that, let's dive in. If you guys are ready, let's show you Clinicom. Okay. Before we go into the platform, I just want to kind of walk through what you're currently experiencing and your patients are currently experiencing without Clinicom, right? So right now, at some places, if you don't have a standard process, you might have some inconsistent screening process. The majority of the first appointment is spent gathering all this data, and who's gathering it? Is it the screening person? Is it the clinician? So you have low equity, low access, and misdiagnosis rate. Standard misdiagnosis rate in the industry right now is 39 to 90% from NIMH data. And so you also, without Clinicom, your intake process may be inconsistent depending on who's working that day. Is Sally working who does a good job, or is Susie working who shows up late? With Clinicom, it's never late. You can do this at 3 in the morning and get the same result, right? You want to screen 10,000 people, you want to screen one. It's exact same scalability. Your notes will never be generic or subjective. They will always be by the DSM criteria and well organized and completed immediately for you. It really provides an objective view. And so you'll also be having some treatment planning measures. So you'll be able to plan treatments and look at efficacy of outcomes and move things from subjectivity to objectivity and more evidence-based with some follow-up features, tracking, reporting. There's a lot of analytics, and will also help lower your documentation burden. So without Clinicom, you're spending a lot of time typing notes, taking an intake, remembering what they said, recording sessions. Screeners are spending a lot of time taking notes, transcribing that into EMRs. We remove that entire burden from you guys. It'll literally be looking at the data, making decisions moving forward. Time efficiency, it's just going to increase your ability to see more patients, put more patients in TMS chairs, and you'll have this great data analysis and ability to assess the outcomes from every cohort level, right? So how's my TMS site in Virginia doing versus my Florida site? How are my outcomes looking? What is that analytics side of things from a patient level all the way to a high cohort level? So that's the high level workflow and the high level output. What I have on the screen now, and Doctor, if you can see, can you see the TMS test account?
Yes, we can.
Okay. Before I go into the platform, do you want to have any questions from the materials before I dive in to show the demo?
Oh, sorry. Yes, that would be great. And I really appreciate this conversation, Iggy. I think you're hitting on some really key components here in terms of what Clinicom can do from an efficacy standpoint. And I just want to point out one thing, the revenue generation too, for private practices and clinicians. There's a strong element of not just getting reimbursed, but using those resources to enhance what you do in your clinic and your office. So it's not just from a diagnostic and clinical perspective, but also from a revenue generating and operational perspective. I think there's a lot of value here. There is a question from Jill in the chat box. How would this work in a ketamine clinic situation? Are you working with many ketamine clinics?
So sure. We have a ketamine clinic. We work with TMS centers and ketamine clinics across the whole country. We're in 33 states. So I think that's a great question, and it segues right into what we're about to show. So imagine that this is your clinic, right? And it has, wherever you see the Clinicom logo at the top left, it has your logo. And instead of saying TMS test account, it says your brand. So this is white labeled to you, right? And when you land on this is not any software you have to download. This is a web-based cloud product. You log in at clinicom.com, you have it, or you integrate this with your EMR and you have it single sign-on within your EMR. We have APIs to do all that. But basically, you start here, and the first thing you would do, and the manual version, so there's an automated version. Let me show you the manual version. The manual version is to come here and select the initial global assessment you want to send to your patient. So Clinicom Pro is the big assessment. Think inpatient hospitalization or somebody with SMI. You really want to weed out SMI. You want to do the bigger assessment. Both Clinicom and Clinicom Pro screen for 80 conditions. This one just captures all the social determinants of health. The Pro does. Clinicom Regular is 80 conditions with less biopsychosocial. You select an assessment. I always recommend clicking both. You enter an email, a phone number, hit send, it's done. We never charge you for an assessment unless it is 100% complete. If you have 68% or 90% or 92%, 99% complete, you will not be charged. The way we charge for the assessment is $12 to monitor that patient for an entire year. Every assessment you want to run that's in our platform, that's available to you, you can do daily, weekly, by the minute, by the month, all assessments for $12. So you have multiple points of potential revenue source, but you only get charged one time for that year, and only when they complete it. So what happens next is, let's just say you're a screener. Yeah. Sorry. Go ahead.
Per patient per year is what you're saying. $12
per patient per year. So what happens next is you land in your Clinicom portal and you have all your patients. These are your patients that have completed your Clinicom And you can track if they're incomplete, you'll see the progress of what the completion is tracking. You'll see all the assessments. But basically, it auto codes red, yellow, and green. What does that mean? This is either green means you technically probably very high likelihood. This is not diagnostic. So let me pause here and just point out we are not a treatment and we are not a diagnostic tool. We are an assessment tool that can show you the DSM criteria and you as a clinician make that decision. So the green is showing that most likely this patient has met criteria for either ketamine or Spravato or TMS. The yellow means they potentially in the future could meet criteria, but are maybe missing one thing. Maybe they only tried one medication, or maybe they're in therapy and haven't finished and it hasn't worked yet. Red means most likely they will not meet criteria, as in they don't have, by DSM, meet the criteria for depression or anxiety or OCD or whatever the parameters might be that we set for you are. So as an example, let's look at a green good to go patient. So this patient, you open it up and this patient has a lot going on, a lot of conditions. The first thing I'm going to point out is that everything listed here, except for your flags at the top, anything with a green to red heat map, is going to be different on every patient. So this is basically the algorithms that they triggered when they went through Clinicom and that were clinically significant, right? Obviously, this is an exaggerated demo patient. Everything's 10 on this patient. It's going to be up and down and different for everybody. And we'll see a couple of those in a minute. But here you can see that this patient had, their green light to go on the pacemaker. There's no pacemaker metal implant. There's no known seizures. There's no uncontrolled hypertension. There's an issue potentially because they maybe had a flag for bipolar in this bad example here, and there's some schizophrenia. So this example really is a flag of, maybe this patient should be auto flagged to yellow because it sounds like they have a lot going on, right? The other patients, if you see all green flags, then it will auto sort it to green. And so you won't have, you'll know that the patient might meet criteria. In a minute, we'll go into the report and we'll see a report, but I want to show the triaging on this and then we'll show another patient. So I wanted to show how we're changing the flags. The other point is this patient here, potentially the reason it's still, the other patient was still green is because maybe they didn't need the requirement to get Spravato, right? Maybe they needed that requirement for TMS, and you can flag them green because you know that they're going to be Spravato and not TMS, and you can change that color to whatever color you coordinate in a company. So if you decide that Spravato means blue, you can make them blue, right? And you can check off if they've met MDD criteria, OCD criteria, and we'll go into the report and see the details here in a minute. But you can see, obviously, the conditions. These are very exaggerated cases, SMI cases, and the reason we exaggerated them so that you guys can see the depth and breadth of the conditions we're tracking. Another example would be if the patient is just not going to meet criteria. Well, let's say you put this on a QR code, or you send an email, or you have a flyer that went out with QR codes. A patient screens, they completed 100%, and they're a red flag. Well, this is a patient they may be really excited about your treatment. They may really sound really great on the phone, but until you bring them in and waste 20 or 30 minutes with them or an hour, you may not know this was a waste of time, right? But for ketamine or TMS, and you may meet with them and then decide that the treatment course is different. It's more medication management or therapy. But for TMS and Spravato, business-wise, that wasn't really your optimal patient. Well, now you know, and you didn't waste time, and you can actually set them up for a behavioral health med management appointment instead of a TMS screening appointment. So it's really care navigation and care coordination that this really helps. And the flags are in the report as well. So in the report that you open up and see, which we'll do that now, you will see the flags at the top. So you will see if you see all green or what things are missing or not, you'll be able to adjust. There's also a note feature in the TMS customization where you'll be able to set a note to, let's say you have one prescribing nurse practitioner. You say, hey, I'm referring you Bob Smith. They probably need med management. And if it doesn't work out, pass them back over to me, right? So it's that care coordination and that navigation of care. that you can review the report and go through it in detail. These are not the best sample patients to look through a report. So let me address the flagging question, and then I'm going to move to the standard Clinicom demo page that has like better patients with real de-identified data to talk about the reports. So let me pause there and answer any questions about the flags or how that works.
Don't have any questions in right now, but I have something that kind of popped up in my head, and well, two things. One thing I like to say is that this is really helpful, not just for the contraindication checklist that we have for TMS providers and even ketamine providers, but for TMS reimbursement, there's an authorization process. So making sure that patients meet criteria, this is actually really effective and really helps keeping the information that's done during the intake, the collateral that's extracted, to be more streamlined. I think for a patient experience, this makes it easier for the patient not to have to fill out a plethora of forms online, do something in their own, or sorry, on paper or on a tablet when they come into your office, and everything kind of gets streamlined into one little chart, if you will. So I like the fact that this is really helpful. My question for you is, can you share, you know, how does Clinicom ensure the privacy and security of all this user data, like especially when all this sensitive information from a security standpoint? Is there anything that you guys do from that end that has been implemented and you know, in compliance with relevant data protection regulations? How would you answer that?
So that's a great question. So one, we are HIPAA compliant, GDPR compliant, FDA Part 11 compliant. The FDA Part 11 compliant means that all our data and everything in the system is tracked, measured, and monitored. So that means every keystroke, every touch of the button, every IP address. There will never be a case where you say somebody moved it and I have no idea who did it. You'll know exactly who touched what time of day, what IP address they came from. We also, like I said, in the report, so you'll also be able to select by the date and who did it and the user, and you'll be able to export this activity log. The other main point to make is for your patients, they get an explainer video when they start, right? So it's not just here's an assessment, start asking questions. It's a 2 or 3 minute explainer video that talks about safety, security, making them feel comfortable, making them, and we can also for a small price, white label that video for you. But we can basically educate them about what they're about to experience, and that we decapitate their private health information and store it in IBM secure underground bunker at, you know, really high encryption level. And then your answers to questions are over here in a different database, encrypted also. And that your only person that's going to be able to look this up is going to be your clinician with access to this portal. And when they open it, their key as a clinician allows that PHI and those answers to come together in a built report. So your built report that you saw on the screen is not sitting in a folder somewhere. It literally is built and pulled together when you call for it. So that's extreme security, right? And to the level that patients have told us about rape, incest, abuse, traumas that they didn't even tell their doctor they've been seeing for 3 years, all kinds of stuff that you just couldn't imagine, because they felt safe and secure, and they know that we'll never sell their private health information. We do look at the outcomes data. So how is Prozac working in 16-year-old females in Wichita? We might, extract that data and review it for studies, but we're never going to sell Sally Smith, demographics, address, sell it on the market. Absolutely never.
Understood. And one more question. Thank you for that, Iggy. That's really helpful to understand. Can you integrate this type of software into existing EHRs in terms of the integration process, and to have that collaborative sense into one internal system? Is that something that our clients and clinicians can do?
Absolutely, and with bells and whistles. So our platform is API based. Our chief technology officer founded the life science division at Microsoft Life Sciences and was sat on the commission for CDISC. So we are API based. So if you do Fire, HL7, LAMP, any API, we have a open API. So you can, if you have tech and dev teams that want to integrate themselves, it's a la carte, self-serve. We can white glove service that and build it for you. If it's a modern EHR, we can likely integrate.
Wonderful. Thank you. That's great to know. Yeah. Awesome.
We were on the Epic App Orchard in 2017 before Silver Cloud said they were the first mental health platform on there, but that's a different point. But yeah, we've been doing it a while.
Gotcha. Thank you. That's great to know. That's really, really helpful.
It makes it all more simple.
No other questions for now, so we'll keep the ball rolling.
Yeah. So I'm going to move it to a clinical discussion. So the flagging TMS product stuff, I'm going to pause for that for just a second, because I want to talk about just the clinical review of the report, how you accept, reject, and some of those features that are really awesome and really add tremendous value to TMS and Bravado clinics, but also behavioral health integrated clinics that have other service lines they need to feed and care coordinate or referral sources to help. So I'm loading that case studies page real quick, and then I will share my screen. Okay, I'm loaded in. Let me know when you guys can see it, and we'll get started.
All good. We can see it.
Wonderful. So this is just the same portal type. Notice it looks the same. It doesn't matter if you have 50 sub-locations and 100 employees or 1,000 employees. If you have multiple locations, your master portal will have everybody below it. There's automatic training. There's automatic, LMS system in here. So, scheduler trains for 15 minutes, billing person trains for 20, clinicians trains for about 40 minutes, and you're done. You're trained, you're certified, you know how to use the product. So it's very scalable, easy to use. You can plug in the invitation, and you can look at your invitations that are pending. So your scheduling person can, resend pending invites. There are reminders built in. We get a 94% completion rate because of our baked-in reminder sequences that you as a site can auto set your own reminder sequences to optimize your reminders for your setting to your liking. But most times with our default setting, we get a 94% completion rate with no human intervention. So let me repeat that. If you send out 1,000 Clinicom invitations to known clients expecting to receive the assessment, that you've told them that you're going to get this, you're going to get 940 of them completed without you lifting a finger. Okay. You're always going to have that small percentage of people that, maybe have a connectivity issue. And in that case, you can literally tell them to come to your office, hand them a tablet, click the add a patient button. And literally when you click this button, it transforms the screen to the patient login. You hand them the tablet and it's done. So there's multiple modalities to get this done. You can also invite and literally put your encrypted link for your site into your Salesforce, CRM, EMR. So what I'm trying to emphasize is multiple ways to get this to your patients. We get it done for you. We train your staff for you. We have white glove customer care and service. There are no charge for installation, startup, anything like that. We just come in here, give you a free trial. You get going, you make money, bill insurance. You love it. It's a subscription and a BAA. We get you going. So to dive a little deeper on the clinical side, here's a bunch of patients, all different with So, doctor, if you'd like, maybe pick one that seems interesting to you, and we'll take a look at it.
Yeah, let's with the recent discussion of Matthew Perry and addiction history, let's look at substance use disorder just to kind of touch on some relevance of recent times. Obviously,
Sure.
very unfortunate what happened and very relative to today's conversation, right?
So, yeah, for ketamine especially, we wouldn't want to use that product on people with that issue. So this is a great segue to that. So the summary of this patient, you can see here when I scan him that he have had several assessments. So the follow-ups here are automated. And you can see, just tracing back, the delta from baseline from previous visit and the delta from the baseline on this condition. So overall, if you're seeing green arrows, patient's getting better. You're seeing red arrows, patient's getting worse for that specific condition. You can see here that they didn't flag as many things, but you can see what they flagged and what severity it is. And over time, if you measure something, I can see their PHQ-9 scores automatically over time, right? Unlike an EMR PHQ-9 that may be taken in by a nurse. I mean, I remember last time I was at a primary care doc, the nurse asked me if I was depressed. I said no, and she literally clicked through the PHQ-9 without asking me a single question, right? So this gathering it directly from the source in the horse's mouth is going to make your data output and your outcomes data way more reliable to what we call in research the Alcoa standard, right? Attributable, illegible, contemporaneous, original, and accurate.
Right.
Yeah.
It's much more organic in context. And one thing I'd like to point out is, with my experience as a TMS clinic owner and operator and provider, we had patients that were using cannabis and alcohol and would monitor PHQ-9s. And what I really find valuable here is that I can actually pinpoint and say, look, you did a whole course of TMS, you had a great response in terms of your depression, and now that you're in this level of remission, I see you for a 3-month follow-up, and you're having a relapse of your symptoms. What's changed in that history? And I wasn't able to assess the usage of any substance at that time. I had to extract that information through collateral history taking after those follow-ups. In this instance, I could have had that right in front of me and said, hey, I can make the connection. There's a correlation here between you having a symptom relapse and usage of a certain substance.
You don't have to dig it up. It's right there in your face, ready to show you and highlight, right? And you could say, hey, look, what happened, Bobby? Things changed since last visit. Tell me about that, right?
Sure.
You can also compare conditions over time individually. So if you say, hey, I want to look at, how's my substance abuse comparing to these anxiety symptoms over here, right? Side by side. So there's some other little features in here that are kind of interesting from a clinician overview standpoint that are kind of very helpful. You will see all their medications. So past, current medications, there's an entire FDA formulary tied to the FDA website. So every night at midnight, we literally, any new updates to drug dosage or whatever, it's all here. And this could automatically be pumped into your EMR, right? But as a Spravato or ketamine clinic or TMS center, it's right here for you. Past, current, medications, and then obviously the diagnosis, right? So we do not diagnose, we suggest, and we don't suggest that you review diagnosis here. This is where you should modify a diagnosis. So something you've already done, you can adjust the severity of it, make a note, and, add a diagnosis that maybe for some strange reason, 1% chance that we miss something, you can add it manually. And then you can also create a follow-up. And the follow-ups are really cool, and we'll get into that in just a second. But before we go in, let's just look at a report. Let's look at this guy's detailed report. So the report tells you how much time it took to complete. Remember, this is adaptive, and this is a very significant SMI case, so it took a while. The average time to completion for a Clinicom is 28 minutes. You can get one done in as quickly as 15 minutes. If you're not sick and you have no issues, it's a 15-minute assessment. If you have 1 or 2 conditions, it might be 20 or 30-minute assessment. If you have SMI and a ton of history and a ton of meds, it's going to take you a long time, and that's okay because you need it, right? It's basically adaptive to the severity of the case. It also shows you the quality of the reporting. So we know exactly how long it takes on average on hundreds of thousands of assessments to answer each question. So if you take too long to answer it, or if you're blowing through the assessment, it will tell me you're above or below the average. And that way I know if the data quality is low, right? So there's a certain measure of quality there. Demographics, there could be, nothing here or 38 features. We can assess that when we set you up, depending. We don't want redundant data that you're already capturing in your intake or your EMR, but you need enough that you need, all the medications, what's been gathered by the clinician. And then here you have the summary. So for this particular patient, there's a lot of substances, ADHD, strong cannabis use, potentially some acute stress disorder, so some PTSD-like symptoms, OCD. So let's dive into one of these specific conditions. So you would click on the condition, it would drive to that level area of the report, so you don't have to scroll. It literally auto-clipped all the data you needed for your EMR. If you're manually moving this into your EMR, you have the note there that you're building. You have the criteria that they give for PTSD. So it did not pump out PTSD. It said a little bit less than that, acute stress disorder, something's acute. So you can see here, review the criteria with the patient. You can also look at the actual questions they were asked by hitting the question mark in the top right corner and review the actual questions that they got for that candidate. And that switches because if it's first person, third person, the questions change, and also by age. So it's adaptive. So if you look at this question, you're like, oh, that's all the questions they asked for that section. No, that's all the questions we asked for that section for that type of patient, right? So we have thousands of questions, and it just depends on which patient. So for PTSD, which we'll review in a minute in the algorithm builder, you can see all the criteria, review it with the patient, and the left-hand column is just a summary. It's not the question the patient got. It's a summary of that criteria. You can review with your patient, validate the answers, and then with the patient, accept, reject, and rule out your diagnosis. So we're not diagnosing anything. We're saying, hey, doc, you're the expert. Here's the criteria. You review it, validate it, adjust it, make the decision. And that has a really profound impact on the follow-up, because accepting and rejecting actually does something. It's not just for labeling the patient. What it does is it auto sets up your follow-up. It helps you, guides you to automation for your next steps and treatment tracking. And we'll get to that in a second. Let me pause there for questions, because I just threw a lot out.
Yeah, no, Iggy, thank you. This has been really helpful. And to your point, I'd like to say that for a clinician doing an assessment or evaluation, rather than having to think of what to ask next, you can actually, touch base on some of these symptomatic states and ask about the catatonia or the negative symptoms, or, the recklessness, the whatever the symptomatic presentation is, to confirm whether or not that's accurate. I think that's a great tool for clinicians for a more effective assessment, and probably more timely from the way I look at it, because a lot of times you ask certain open-ended questions, a patient will give you a Pandora's box of information, which maybe only 10% of it actually is pertinent to what you're doing in terms of history taking. So I think this is extremely valuable. A question we have from Elizabeth. Thank you, Elizabeth, for the question. Other than the cost of $12 per patient per year, it's not per month per patient per year, is it? It's per patient per year.
$1 a month,
right?
$1 a month a patient. You can think of it as that. And if they don't do anything on that patient in year 2, they'll never get auto charged that $12 again. If you see that patient in year 2 and you click another assessment in year 2, is the only time you're buying another year.
By another year. And is there an overall cost for the software license?
Nope, it's free. We actually, for free, let you make money on it for the first 30 days, right? At the end of that 30 days, you can decide to move on with us or not. Risk-free, no requirement. And if you decide to move on, because you're going to be so happy, all the time it saves you, the next month you don't get billed to the end of the month, so you'll have actually gotten reimbursed probably. And when you get your first bill, you're going to be smiling, because the money's not coming out of your pocket. You've already had generated revenue. So that literally,
I'm sorry again,
no upfront cost.
And I think it froze on that explanation. So you were saying there is no overall cost for the software license.
Let me try
free.
to recap.
Yeah.
There is no upfront cost. You get a free trial for 30 days, and the second 30 days you can continue to use it, and you don't pay your bill to the end of that. So for the first 60 days, you're generating revenue, and you don't even have to pay your bill to the end of the 60th day.
And in terms of the generating the revenue, what does that process look like for a provider in terms of what they do and how long it takes?
Yeah, so you're billing the 96136 code, which is or the 96138 code. The 96138 is a technician code for sending a Clinicom and doing this level of testing. And then the 96130 code is done when you evaluate the patient. They come in and you screen them and said, okay, this is a viable potential candidate. Let's actually bring them in for assessment. And then the clinician actually sees them. The MD or PhD actually assesses, reviews a Clinicom, and they're paid on the 96130 anywhere between $80 and $100 for evaluating the Clinicom and making clinical decisions as to what the next course of treatment is. Once you start TMS treatment, you can no longer bill these additional add-on codes, but if you move them to medication management until they are applicable, you can use units for testing. You just can't double dip on testing during the TMS. Now, since you've already paid for that patient, all that PHQ-9 tracking for that year through TMS is included. So you get all that data. Right? You get it anyway.
Gotcha. Gotcha. Oh, so Elizabeth's follow-up question is, okay, so to clarify, after the 30-day trial and the end of the second month, there is a cost for the software license, correct?
No, so there is no license annual fee for the license. It's just whatever you use. So if you use one, you get a $12 bill. If you use two, you get a $24 bill. Right? If you sign up 2 patients, you get a $24 bill. It's per use and only per completed. So if you had the number of completed patients at the end of that month, that second month, you'd be billed for those patients for that second month, and the first months you got for free.
So there is no license annual fee. Depending upon the number of patients you have, you pay $12 per year per patient. That's it.
Done. Like, listen, there's other companies, I'm not going to name their name, but they've been charging us clinic owners and clinicians per test, per this, per that, and it's annoying, right? I mean, who wants to take a lick every time you have to hit a button?
Yeah.
So yeah, we're just trying to solve that problem.
And this can be billed by an MD or PhD, correct? Not master's levels nurse practitioner or master level therapist.
It's very clear and on most CMS codes that these codes, the 96136, 38, and 130 is for MDs, PhDs. Absolutely. You guys build those codes sometimes anyway. But for master's level, it's not available. What it is, the billing reimbursement. For nurse practitioners in some states, some insurances, they are capturing it. And that's a per state. I have to let, we have people to look at that for you. I'm happy to answer those questions. For most of the models that can't reimburse, so counselors, therapists we keep the price so low so that they can, if they're not seeing Medicaid or Medicaid patients and they're cash pay, which the majority of them are, they can resell the product for $20, $25 and charge the patient that number and make revenue that way. That's why the price is so low. It's one model for everybody.
Gotcha. Awesome. Thank you, Iggy.
Yeah. It's about equity and access for us. The other thing I want to point out is the adaptability here. So you can see here, this patient said, I don't use tobacco. Why am I going to ask you 20 more questions about tobacco? I've never used heroin. Why am I going to ask you 20 more questions about your heroin use? So it saves time from that, right? If you're not anorexic or issues with weight, then and your BMI is normal, why am I going to ask you those questions? So the adaptiveness is that basically every report you're going to see is going to be different for everybody, but it's complete. It's what they needed to know, what you needed to know about that patient. So the example there to switch to is a different type of patient, right? So that guy was interesting, but let's look at, for example, somebody with 2 assessments, potentially. Let's do this bipolar patient, because you don't need bipolar people in your ketamine treatments. So this bipolar patient's had a couple assessments. Their report is going to have a different layout. It's going to look different. It's going to have tailored to this patient. It's going to be, we also, at the top of the report, and this is important to note, for the TMS product, we have the flagging and the green lights and the circles here. But we also, in every one of your launches and instances, we ask you what you want your control arm to be. Most clinics pick PHQ-9, GAD-7, DAS-10, and Audit C. So we left that as the default. We have hundreds of other assessments. So you could come to us and say, we do a lot of sleep stuff. We do a lot of addiction stuff. So it could be the control arm here, could be anything you want us to monitor. Obviously, for TMS, you might want the top 2, right? You may not want the bottom 2. You take those out. So we can set the control arm to be whatever you want. We have a lot of data showing how inaccurate the PHQ-9 is, and I can't wait to publish some more of those studies to kind of just put that to bed. The bipolar section here, the mania section, you wouldn't want one of these patients taking Spravato. So it will flag. It will actually tell you under the condition if it met criteria or not and which subtype. So if they don't meet criteria, it will also show you so that you're not spending time reviewing systems on things that are wasting your time and they don't have criteria for. You can also just copy and paste and build notes as you go. So if you're like, hey, I want to grab this information about the learning disabilities, it just added it to my note on the right? If you want to say, hey, I want to grab this information about insomnia, it just added it to my note on my right. I just copy the whole thing and paste it. I can print the whole thing to my EMR and save it as a PDF. I can print out sections like I'm doing with a copy and paste. So there's multiple modalities to get this information into your EMR or into your paper files. And you can jump across the sections of the report and say, hey, let's just look at this bipolar patient's family history and their support system, right? And here you see all the biological medical and psychiatric ismay alcohol abuse, right? We have hypertension, we have heart disease, right? So this may be somebody you want to flag for some of those other treatments. And the TMS algorithm will already do that for you. You can see here there's depression experienced by a lot of people in the family, bipolar disorder all over this person's. So there's genetic loading here, right? So this is not just the DSM criteria, it's also the biopsychosocial, historical, contextual information about their support system. So this is a Clinicom Pro. This is not a Clinicom. This is the deeper dive assessment. So depending on the setting, you may want to go that deep. You may not want to. You may want a lighter assessment. we can also customize that if you want us to pull things out and tell me, I don't want to look for enuresis and pica, Iggy, my population doesn't have that. We just pull cords out. So if you only want 60 conditions instead of 80, just let me know which ones you want gone.
Mm.
No.
Good to know. Good to know. Iggy, I really
Okay,
appreciate you doing this. This is really helpful. Yeah, of course. I know we're short on time. We're gonna have to wrap up soon, but I think there's a lot to discuss here. What I will say is that this type of resource is instrumentally helpful on the outpatient setting, and what we have to do is provide the access to this type of stuff. So beyond marketing, we'll provide all of our clients access to Clinicom in terms of not access to Clinicom, let me rephrase, an opportunity to join Clinicom as a client. If you're interested, we'll definitely connect Clinicom and the team and Iggy with our clients as well. But this is really helpful. We really do appreciate this, Iggy, and I think there's a lot of value here. And I don't think this is the only call we're going to have. We're going to have another one to kind of go deeper into this. So we'll definitely have
we
one
didn't get
starting
to
Q1. Yeah, we have a lot more to discuss. So we'll have another call next month for sure, or if not, the month after for Q1. Definitely look at our schedule and see if we can get something on the webinar side of things. But there's so much to tap into here. For any of our clients that are interested in these services, what Clinicom offers, please let us know. We'll definitely connect you guys. We will send emails out to a number of our clients that are registered for today's call with some links, and we will take it from there. Iggy, I just want to say thank you again for doing this. This has been really, really helpful, and thank you for what you're doing. You're really helping change the narrative and provide better access to care.
Thank you so much. It's a pleasure to serve. And, we're always here for you guys. And if you need help, just go to clinicom.com/onboarding and just make a note when you go there that this is from Beyond Marketing. Thank you guys so much.
Appreciate it. Thank you, everybody, for joining. Thank you, Iggy.